On this episode of our mini-series on the NHS here on the Sky News Daily, we really are looking to the future and how technology could help the health service in the future, particularly in cancer care. A diagnosis is obviously a horrible time, but long term, we're going to talk about exciting developments in this field as we continue to ask the big question of how do you fix the NHS? I'm Sarah Jane Mee, and again joining me is Sir David Nicholson, who used to run the NHS in England. This time, we're with the man leading surgery at the Institute of Cancer Research.
A simple blood test that could actually detect whether there are any circulating cells that are changing into cancer. That is going to be transformational.
Professor Lord Darzi, as we explore cancer care. There's recently been changes to cancer care waiting times in England. 3/4 of people should have a diagnosis in 28 days, and then 85% of people start treatment within 2 months of an urgent referral. We'll talk a little bit about targets and if they work. But first, another story from you. This is Graham. He was 55 when his prostate cancer was confirmed back in 2019.
My diagnosis was just literally a few days after retirement from the fire service. My specialist nurse called me in along with my wife. She sat me down and she said, "I'm sorry to say, Graham, you've got aggressive grade cancer." That emotion immediately was, filled with fear. You instantly think of death and you just have so many negative thoughts. I went home with my wife and had to inform my daughter. I still get emotional about it today. She was 18 years of age then. It was a dark weekend. What's going to happen next is a big question that you hold for a long, long time. Within 3 weeks of being diagnosed, I was in having surgery. I was provided a wonderful specialist nurse called Claire, who from the very onset, she not only delivered the information, but she provided reassurance and guidance. It was Claire who provided honest feedback of what would come next and what that actually meant. She wasn't just talking to me, she was talking to my wife and holding her hand. Claire became a real important element of my recovery as well. Without her being by my side, my journey there afterwards would have been so much harder. If I'd been a little bit older, things might not have happened so quickly. I had robotic surgery, which is fairly unique in this day and age. It's less invasive, more accurate than what would have been done in the past. And you also have a quicker recovery time. The pandemic actually fast-tracked some very important drugs through the system. I've ended up going down a route of hormone treatment and a chemotherapy drug. When I look back at my 4 years of having prostate cancer and the journeys which I consider to be a roller coaster, I know now that I'm on a suppressive pathway. Hopefully one day there will be a national screening program for men so that men stop dying of it. I don't believe that I would have managed to get through where I am today without the NHS. It's been my lifeline.
Prostate cancer is the most common cancer in men, and Graham is among the 1 in 8 men who are diagnosed with it during their life. Sadly, the stats show us that more than 12,000 men are still dying each year in the UK with this type of cancer. David, whatever type, cancer is something that touches so many of us in some way or another, whether it's getting that diagnosis yourself or a loved one, a close friend or work colleague. But it's not all doom and gloom these days.
There's been a kind of a revolution in attitudes to cancer. Not long ago, cancer was seen as a death sentence. And to be honest, quite a lot of people still feel that it is simply not true. There are lots of treatments now available. Cancer can become a long-term condition. With that, a whole load of technological changes have gone along at the same time. In the meantime, one of the things that we constantly try and do is benchmark our outcomes against other people. Mm-hmm. And I'll be interested in knowing the conversation whether this is still the case, that our outcomes in this country are worse than most OECD countries. Not in every cancer and not in every arrangement. I think there's been consistently an argument about data. And most of the conversations around this have been identifying late presentation as the thing that distinguishes from others. This idea that people delay going to see their doctor if they believe they've got some problem is a big issue for us, and too many people are diagnosed with cancer when they come into ED as an emergency. And so they're the sorts of things we really do need to start to tackle.
Professor Darzi, Lord Darzi of Denham, is Chair of Surgery at the Institute of Cancer Research.
Eric, the issue about whether we are performing worse than the rest of Europe in all of this, is that still the case?
With the caveat that essentially you're not comparing like for like in many European countries, but overall we are doing worse than they are.
The standards that the NHS have set, we talk about the faster diagnosis standard. You should receive a diagnosis within 28 days. The target set for that is 75%. You should begin treatment within 2 months of referral, treatment within a month of the decision being made if you wanted to have treatment for your cancer. This all sounds extremely positive. Is it working?
I speak as a clinician where at the time I remember when these targets came in through the NHS plan, there was a serious dissatisfaction by the introduction of these targets for all sorts of reasons. One, the targets became the end rather than a means to an end. There's been a huge amount of change in many of the targets, but there are more what I would call intelligent targets that actually reflects at least the whole journey of the patient. And I think, yes, I do believe in it. And I think we should constantly review them to see whether they're doing what they're supposed to be doing and refine them.
David, there are so many different types of cancer. Everybody's cancer is personal and it's just such a complicated issue. Do you think standards and targets work in practice?
Targets on their own are never an answer. I was particularly cognizant when looking at cancer that it is systemic. A whole load of things need to happen to get the best outcome for an individual patient. If they're seen as individual separate targets, then they won't work, because people need to understand why they're doing what they're doing. And if all people want to do is tick the box, they'll miss the point, because the whole point of it is to get the whole patient journey as rapidly sorted as possible in order to get the best outcome for a patient. You go into an organisation and you talk to the clinical team. If they understand why they're doing it and they understand why it connects to the other bits and they can work out how things are supposed to work, they're more than happy to deal with things. If you go into a clinical team and say, just do it, this is the target, you've got to deliver it, you get a poor response. So it needs proper, nuanced management to make these things happen. But targets are a very powerful way of driving something forward, if done in the right way.
What do you think is the next step for improvement in this area? David, I'll go to you first.
The use of innovation. Often people think that it's inventing new things, but it's also about getting people to adopt things. My guess is somewhere in the country we have, fantastic health outcomes for individual cancers. And so the question is, how do we get everybody that? How do we get adoption throughout the system of the best way of doing it?
The more and more we understand the biology of cancer and its sinister behavior, the more at all levels, cellular and beyond, we're really getting to know that cancer is not a homogeneous cancer. That complexity has been unpicked over the many, many decades now in terms of cancer care. And that's why we're seeing a tremendous improvement in survival. But there is more to go. Personalized medicines, where you actually could tailor a drug based on the genetic makeup of that tumor. And as we may know, as we've lived through COVID, by the way, tumor cells also evolve, and there are variations of them as you treat them. And so the science is really looking at an individual's genotype, phenotype, and design and tailor drugs in the future to treat them of cancer. One of the other great advantages of our system, we have NICE, we have a very good innovative regulator called MHRA. So when a new drug comes out, one of the big challenges is to get the cost effectiveness and all of that done. But in cancer, there's a faster pathway. So access to these is becoming more and more relevant.
I hear that so often when I interview people on Sky News about cancer. It's about having access to what is already there. People are seeing that as a big stumbling block when it comes to individualised or personalised care.
You shan't underestimate how difficult it is to identify the particular drug with the particular dose to deliver improvements for a particular cancer. The genetic work that Ara's talking about enables you to be really specific about the type of drug and the type of dose you need for an individual. I don't know whether it's moving as fast as it should do. Certainly 7 or 8 years ago, it was going to be the answer to all of our problems. I don't know whether it actually has turned out in that way, but I think that is a really important step forward.
In a moment, how artificial intelligence is helping in the fight against cancer. When we talk about technology, we often talk about artificial intelligence, the importance of digitalising patient records, and the importance that they can make in cancer diagnosis and treatment. Lord Darzi, perhaps you could expand a bit more on developments in this area and the hope that it gives you for the future in this field.
So one amazing study that the NHS is contributing to is called the Galleri study, which is really for early detection of cancer. These are a simple blood test that could actually detect whether there are any circulating cells that are changing into cancer. That is going to be transformational. These are the tests that might be a bit cheap. They're accessible to all ages. You can repeat them based on risk. And that is going to be really shifting the needle, because the earlier a patient presents with cancer, the better chance they are of a cure, the better opportunity they may have with technology. We can actually reduce the invasiveness of this procedure.
The thing you said earlier on about the regulatory regime, NICE, MRHA, and I guess there are CTA, there are lots of regulators around. Do you think it's sufficiently organised to enable this innovation to take place? Or would you say it's potentially a drag?
A safety regulator's role is never a drag. Actually, it's absolutely vital that we have a regulator of that strength who scrutinizes both the manufacturers, the technology, and the evidence to support its adoption, and let alone cost effectiveness. Nowhere else in Europe could. And say, listen, there is a big issue on early cancer detection. Most of our cancers are later presentation in the UK. Let's find a partner. They found a partner and they've launched this major screening program, but its early results are very promising. People who are completely asymptomatic, in which you can pick up few circulating DNA cells changing, which will actually direct you to where that organ is and try to put that patient on a very stricter follow-up screening program.
It's hard to underestimate the transformational nature of that. So literally at one blood test, you'll be able to tell, which I think is extraordinary. It's only because we have the kind of health system that we have, which is more integrated, which is capable of doing it on the scale that you need to, that we could potentially get this great breakthrough.
How far away are we from that? Because again, on Sky News, we talk about innovations in cancer treatment all the time. I mean, recently we've heard that the NHS is confident it can eradicate cervical cancer within the next 20 years, which is quite some claim. And when you think of the history of cancer in our lifetime, that's an incredible thing to be able to come out and confidently say. How far away are we from simple things like this blood test? Because that's what people at home want to know.
We are much, much closer to an early diagnostic that I've ever had the feel of in my career. Government and industry signed an agreement and a partnership in running this trial. And we're the first to get access also from the results of this trial. But things are getting even more sophisticated. Personalized medicine is really becoming a significant reality. Once we get an approval through the regulator and also NICE and the NHS, then everyone will have access. That's the beauty of our system. Unlike the US, where I am today, huge inequalities in terms of access and cancer care. They have some of the best in the world, but the majority sadly provides well below what we will call our own standards.
Often when you mention artificial intelligence, you get quite a strange reaction from people, because a lot of people concentrate on the bad, dangerous side of it. But actually, AI is such a useful tool within the NHS. Lord Darzi, I know that you and your team have worked with AI, for example, in helping productivity when it comes to reading mammogram results. Perhaps you can tell us a bit about that and how that's helped.
So anyone who has a mammogram, and if it's normal, then they come back in 2 years to get it done again. It's essentially you're screening a normal population to pick up the few at risk or have changes. And so it's a bit cumbersome, but we do it well in the UK. We're obviously getting, as we celebrate increasing access to screening, we're also having workforce issues. We looked at the possibility of using AI. Could we get an artificial intelligent algorithm to actually look at an image and read it? And then we put a partnership with DeepMind, who are really the kings of artificial intelligence, and more importantly, with Cancer Research UK, who had access to some amazing mammograms ready to be read by a computer algorithm. We have 2 radiologists who read each single mammogram currently in the NHS. But if you bring in this algorithm, the actual AI, artificial intelligent reading of an image, plus 1 reader, you can get away with 1 reader. And the combination of AI plus 1 reader is as good as 2 readers. And I'm sure AI will show even better accuracy as we move forward. So it's not just quicker. Artificial intelligent algorithm could read mammograms 24 hours a day, 7 days a week. So we're not depending. You also need quality assurance by a radiologist. But I just say radiologists are still critical in doing all of this. This is one application. There are many, many others, not just AI in robotics. While you do surgery, AI in stratifying population, identifying who's at risk of cancer. We're just scratching the surface here when it comes to AI.
I can't reinforce it enough, really. I think Ara said it as well, is this, if you see AI as essentially a way of getting rid of doctors, you don't need doctors. That's the threat that people fear, isn't it? The fear that somehow that it's all going to be taken. It's not. Robotics, similarly, you don't get rid of the doctor. It's
it should be seen as supplementary, not a replacement. Yeah.
It's about precision. It's about productivity. It's about getting through much all of those things. And the opportunities are enormous.
It's been such an interesting and insightful chat into this field that is vast and complex. So thank you for guiding us through this. I'd like to end with a message to people who are touched by cancer at the moment. Can you give them a message about the future of what they're facing?
So there's huge amounts going on. There are some really practical things that are going to happen soon. The example of the single blood test for cancer, the implementation of AI, transformation. People may not see what's happening underneath it. And the great thing about it is that we have a healthcare system that can implement these things. Many countries don't have healthcare systems that can. So what happens is part of the population get it and most don't. In our healthcare system, we have the potential to do it right. But we need to be properly organised to do it. And we need to have the managerial skills and the leadership to make this stuff happen. It just won't happen because it's been invented. So, we've got all of the tools there to make a massive transformational change for cancer.
Next time, we focus on one of the biggest post-pandemic challenges, mental health.
Personally, I feel like the system is backwards. It needs to be preventative rather than to come into people's lives when they're at crisis.
How do services need to evolve to meet changing awareness and changing demands? That's next time.